So one of the things, Steve, people will be thinking about is therefore the eligibility criteria. Can you talk us through getting our heads around some of what that looks like?
Sure, Colm. Basically, there's three core eligibility criteria that need to be met to be deemed eligible to enter a Specialist Dementia Care Program unit. The first of these is that the behaviours that are being the cause of the referral must reflect a dementia diagnosis, which raises the question of what does dementia actually mean, because the terminology has evolved over time, and dementia, as we've traditionally known it, refers to a progressive neurodegenerative disease. More recent editions of the diagnostic manuals have abolished the term entirely and replaced it with something called major neurocognitive disorder, which is any condition that causes enough cognitive problems to impact on function. And that can arise through acquired brain injury, through stroke, through psychiatric illness. So whilst dementia is a part of major neurocognitive disorder, for the purposes of the SDCP program, we're defining dementia as it has been traditionally understood, a progressive neurodegenerative disease rather than other causes of major neurocognitive disorder. The reason we've chosen to do that is because, as Anne has mentioned, these are transitional units with an average length of stay that's aimed to be less than 12 months. And if you admit people, for example, younger patients with acquired brain injuries, which are going to be enduring causes of significant behaviours potentially, there's no obvious pathway for a person such as that out of the unit because their behaviours are likely to remain static unless they undergo a further neurological or medical insult. So a dementia in terms of Alzheimer's disease, vascular dementia, Lewy body dementia, anything of that ilk must be the cause, the primary cause of the dementia. I've chosen the words carefully there because I don't want to imply at all that people with comorbidities are excluded. The program's certainly open to people with significant psychiatric problems or who have had strokes or head injuries, but we must be sure that the behaviours that have prompted the referral to SDCP primarily reflect the dementia component rather than the comorbidity component. And our assessment process is geared towards determining just that. People with enduring severe psychiatric illness, for example, might have had a 10-year history or a 20-year history of problematic behaviours. They may then develop a dementia when they reach their 60s or 70s, and if the behaviours continue much as they have for the previous 20 years, it's very hard to justify a position that those behaviours primarily reflect the new dementia diagnosis when they've been justified by another diagnosis well before that. If new behaviours arise subsequent to the dementia diagnosis, then yes, those behaviours can be counted in. But dementia diagnosis is criterion number one. Criterion number two is that the behaviours must be severe or very severe on the spectrum of behaviours that could arise. And we've got the graphic up there which illustrates the Bharati Triangle, which most of our viewers will be familiar with. The SDCP program is geared towards those whose behaviours lie at tiers 5 or 6 of the Bharati Triangle. A couple of important points there. These are not programs that are intended for people whose behaviours sit at the extreme or tier 7 level of the Bharati Triangle. SDC program facilities will not be secure facilities in the sense that long-stay hospitals can be secure. They don't have full-time security staff. It's a nursing and multidisciplinary team load, but not a securitised environment, if you see the difference.
Yes.
So people whose behaviours are too severe to be contained within the program won't be eligible for SDC placement. Neither will people whose behaviours are mild. A very mild degree of behavioural disturbance is very common across the population of people with a diagnosis of dementia. So these are very scarce beds. We need to make sure that our assessment and triage process allocates a scarce and important resource to the people who could most benefit from it. So behaviours in the severe to very severe part of the spectrum, but not extreme. The third criteria is probably a difficult one to get your head around as well. To enter into a specialist dementia care program facility, the behaviours not only need to be primarily dementia-related and at the right end of the severity spectrum, but they also need to have been demonstrated to have been intractable to adequate trials of management. And one of the things that we've learned with the Dementia Support Australia service is that many people with very significant behaviours can have those behaviours significantly moderated with appropriate specialist input. And if we know that in the majority of cases we can settle behaviours down through the involvement of specialist services, whether those services are Dementia Support Australia or the plethora of other public and private services that are out there, it just makes sense when managing, again, a scarce resource to give management in terms of other specialist services a decent go before drawing the conclusion that the only way to manage this particular problem is through referral to an SDCP. So we're not insisting that people who are referred to the program must have been seen by DSA by any means, but we are requiring as an eligibility criteria that some specialist service, whether that's DSA or aged persons mental health or geriatric medicine outreach, or indeed private practitioners, have been engaged to try and manage the behaviour in conjunction with the referring facility. We're requiring the facility have, in good faith, tried to implement those suggestions that the specialist service has put forward, and only when those steps of specialised management have been applied and have failed would we then be looking at resorting to an SDCP facility to try and manage the difficulty.
Now, Steve, when Bharati, Draper and Lowe developed this triangle in 2003, they probably didn't have some of these tongue-tied DBMAS, SBRT and SDCPU things to apply to it. Can you talk us through, we did talk a little bit about the other two services that sit under DSA. So I note that it's really we talk about DBMAS being level 4. Can you talk us through just the triangle in the context of the overall DSA programme?
Sure. I mean, the Commonwealth's approach that Anne referred to in her introduction from this Ministerial Dementia Forum back in 2015 highlighted the need to have services that are targeted towards all tiers of the Bharati Triangle, and specifically in relation to behaviour management. There's been a national dementia behaviour management advisory service since 2007, I believe. The Severe Behaviour Response Team came into being at the end of 2015 to sit above DBMAS in terms of behaviour severity. And the final plank to the government's approach to dementia behaviour management is the introduction of the Specialist Dementia Care Programs that takes the people who have passed through the filters, perhaps, of DBMAS and the Severe Behaviour Response Team and still have problem behaviours that require addressing. Those people are suitable for SBRT. So those lower tiers of behavioural disturbance, if you look at Bharati Tier 1, there's no dementia diagnosis at all, so no need for our services. Tier 2 is the presence of dementia but no problem behaviours. Tiers 3 and 4 relate to mild and moderate behaviours respectively. 5 and 6 severe to very severe, and Tier 7 is those extreme behaviours. So the way the current service network is set up is the DBMAS level cases, the lower intensity behaviours at Tier 3 and 4 are triaged by DSA to the DBMAS program within our service. The more significant, risky and severe behaviours are triaged within DSA to the Severe Behaviour Response Team, and then above that, yet again, is the Specialist Dementia Care Program. Probably worth drawing attention to the numbers along the side of the triangle as well, Com. When Bharati and his colleagues were producing the Bharati Triangle, these were best guess numbers. And if you look at the estimates that were done in 2003 of the number of people who'd be sitting at Tier 6, so the SDCP eligibility territory, Bharati and colleagues estimated that up to 1% of people with dementia could sit at that tier. I think the most recent statistics from Dementia Australia suggest there are about 435,000 individuals with a dementia diagnosis in Australia at the moment. Up to 1% of that is 4,350 people. The SDCP program does not have that many beds. It has around 280 beds, I believe, when it's fully rolled out. So by virtue of running this program, we'll be able to get a more accurate determination of the absolute number of people who do sit at Tier 6 to enable better service planning ongoing.
So, Anne, is that one of the benefits of, as these programs roll out, that we will get more accurate information that will inform how we plan for the future?
Absolutely. I mean, I think, and I I'm very cognizant that you're probably more specialist than I am in this area, but my understanding is that there's a bit of a lack of evidence of true demand for such services, and also in some ways of the effectiveness. So the way in which this program is being rolled out is very much through phases. So we've got phase 1. We have an evaluator who we have engaged who will evaluate phase 1, and we'll go through that evaluation before then rolling out phase 2 and obviously make any adjustments that we need to. So part of that, and a very interesting question, is exactly what the demand is. I think it's also worth noting that the demand is not necessarily static and that people do move between the layers. Yes. or the levels. And because this program is transitionary, we hopefully will be able to have people flowing through the program, which means that we won't, if there's around 300 beds, that's not the limit of the number of people who will be able to be treated under this program or cared for under this program, that we will actually be able to care for more. It's just 300 at one single time.
Jackie Bowden, thank you for your question. Steve, and it relates to what Anne's touched on, is there support for clients living in the community on home care packages, or is this only for clients in residential care? Now, you've touched a bit on the fact that there's a programme that has, I guess, 3 elements to it.
Sure. Yes, people who are living at home are certainly eligible for behaviour management support through all of the services that are available, including Dementia Support Australia. So currently about 20 to 25% of referrals to the DB MASS program are of clients who are living in the community with family or home-based carers. They're certainly eligible for DSA services. They're also eligible for the Specialist Dementia Care Program, and certainly was designed with open access to that group in mind. Mm-hmm. My own thoughts, and we won't see this until the program starts working, however, is that most of the people who will require placement in the Specialist Dementia Care Program are probably already in residential care, because to get behaviours that are severe to very severe, that have been able to be managed by a home-based carer to any extent at all, it's a bit of a long leap to go from a level of single carer home-based care to the most specialised form of care imaginable. Mm-hmm. Most people, I suspect, will pass through a generic residential aged care placement process before they reach the point where they might ultimately need an SDCP place. But it's certainly open to community-based referral.